Hello.
Hello again.
Hello.
How you doing?
Good.
Somehow my Outlook folders got like unalphabetized, right? What is that
Oh,
even? I don't know
Laura.
how to navigate that.
You should be able to just do you mean like Word documents and all those things?
No, I mean like instead of it being like I have like tribal relations, workforce, youth development Oregon, and then
Yeah.
personal, BRS, federal
Oh,
government. Like they don't go in alphabetical order anymore. I
that's weird.
don't know why.
Odd. Yeah. The only thing I think is just click the name category at the top and just see. And if you do it a couple times, maybe it'll
Oh,
sync.
see if it
The
like
next day.
resorts itself. Yeah,
Yeah.
that might
Yeah.
work.
I mean, I don't know how it would have ever gotten that way to begin with, but there's gremlins out there, so who knows?
I know exactly.
Yeah.
It happened when I switched from to the Windows 11 thing.
Oh, yeah. Mm-hmm.
So lots of people had weirdnesses when that took place.
Mm-hmm.
Good afternoon, Jared.
Hey Anna, how are you?
I am well. How are you?
Been all right. Good to see you all.
Good to see you. And Molly, nice to see you here. Alicia, good to have you here too. Hi. Did I pronounce your name wrong again? Alicia, did I say your name wrong?
There we go. Sorry, I was trying to get off mute. No, you said did not say my name wrong.
Hooray! We got
So
it
and
right.
just yes, and just so you know, I'm going to be doing this from the car. I'm driving back from Eugene, but I'm here.
Got you. Okay.
Okay.
Take
All right.
care. Do not look at the screen.
Got it.
Hi, Kate.
Hello. Forgot we were doing this on Zoom today. I had to figure out how to get that to open.
Yeah. Yeah. It's a lot more accessible for our non-state agency partners. Teams is really difficult for folks who don't work in the state. You can't get the documents that get shared in the chat and like all of it's just like it feels very like us and them, and that's not the vibe we're trying to create around here. We have a bunch of people who are traveling today. So let me double check. See, we've got more people rolling in. Need Leah, 1, 2, 3, 4, 5, 6, 7. All right, we have quorum, so we can go ahead and start. This meeting is being recorded. If you are not a person who likes your image to be shared on the internet, please go ahead and turn your camera off. Very welcome to continue to participate, but we will be posting this on YouTube as part of our public meeting accessibility policies. So if that makes you feel uncomfortable, like I said, your best option is to go ahead and turn your camera off. You can still participate via voice and via the chat and all the other ways. We have decided to start all of our meetings with an uh, oppression acknowledgement and our group agreement. So I'm going to read those out really quickly, Leah, and then we'll take roll and move into our agenda for today. I'm also going to try to keep an eye on admissions. So holler at me if you know somebody's stuck in the waiting room. So, System of Care Advisory Council acknowledges the harm and systemic oppression of historically marginalized groups at the hands of Oregon's governmental institutions and system partners. These systems include education, child welfare, criminal justice, health and disability services, and other systems where an overrepresentation of marginalized populations exists. Of particular concern to the System of Care Advisory Council are Black and Brown families of historically marginalized communities, LGBTQ+ youth, and tribal children and families. Our group agreements, how we act in this space so that we can be as productive as possible. We try to be present and participate. We listen to the conversation. We speak up when we have relevant information to share. We treat others with respect. We try to avoid interrupting each other. Sometimes we get excited and talk over each other. That's okay. We just apologize. And we use the names and pronouns people indicate that they prefer to be called. We try to avoid acronyms, use the chat box to write definitions or ask for clarification if someone inevitably falls into acronym speak. It's very common around here. Varied and opposing ideas are welcome. We try to be curious when disagreement occurs rather than defensive. We do our best to honor those with quieter voices. We lean in if we are a quieter person. We lean back if we are a more talkative person. Avoid problem solving for individual situations or crises. Please do connect offline or via the chat to figure out how to get your needs met. But we are here to focus on improving the system of care for Oregon writ large, not individual cases in these spaces. We do our best to be mindful of the variety of power dynamics in the room, and we do our best to avoid harming each other. When that happens, we strive to be open to repair to the greatest extent possible. Any questions or comments about how we do what we do in these spaces? Okay, next we'll do a quick roll call and then we'll hop into our meeting. Ebony?
Hello. I just
Hello.
joined, so am I supposed to be saying something?
Nope, just calling your name, just like you're saying you're here. Here.
Okay, present.
Leah Tucker, Sonia Little Deer Evans. Leah, just unmute and say here if you can. And I don't see Sonia yet. Oh, she's excused. Courtney Esparza and
Here.
Lacey Andreessen. Courtney's here, Lacey's excused. Corinne Hale, Selby Stebbins.
Present.
And Corinne is also excused. This is fun. Nate Latanzio and Wes Rivers. Don't see either of them. Chelsea Holcomb, Molly Haynes.
Yes,
They're-
I'm here.
Gotcha. And Chelsea is here. Remy Watts and Meg Carey.
Here. Hello, everyone.
Chelsea's here, but she can't unmute, so we've got you, Chelsea. Jeremy, oh no, Lydia Pfluger and Jeremy Buchanan.
Here.
Here.
Gotcha. Debbie Martin, Anna Day.
Here.
I don't see Anna, but I believe she's excused. She is. Monique Turner, Alex Sullis.
Here.
Here.
Excellent. Christy Reese and Brian Detman. Don't see Christy. Brian is excused, and Alicia is already here but driving. So we're not going to make her unmute to say that she is here. Did I miss anyone? Okay. So we're going to move our agenda over and make it big enough to see our goals for today. We'll skip introductions. I just did it. We're going to hear from the OHA Ombuds on their 2023 Youth Behavioral Health Report. Spend about an hour on that, and then we'll spend 15 minutes trying to think about how that indicates actions we may want to take on the high acuity end of the spectrum to move the needle. And we'll open up for public comment, and then we'll finish with our post-meeting survey link. Any questions or comments about that? Okay. And we have OHA Ombuds presentation. Is that the PowerPoint you want me to share, Kate? One moment while it loads, please.
Thank you for driving.
It's less awkward if it's me sitting here watching the thing load than if it's you. And slideshow.
While it's loading, would it be helpful if my colleagues and I introduce ourselves?
Sure.
There we are. Okay, I think that's our first slide. Hello, everyone. It's nice to be with you. Thank you for making time with us and asking us to come and join you and speak. My name is Kate Drynan. My pronouns are she, her, and hers. And I have been with our Oregon Health Authority Ombuds team since our inception in 2019. And with me today are one of my colleagues and our manager. And I just want to pause for a moment and ask them to introduce themselves.
I can go.
Oh,
Go ahead.
for it.
Hello, everyone. I'm Brooke Emery, she, her pronouns, and I am the new Oregon Health Authority's principal ombuds.
And I'm Sarah Dobra, she, her, Aya pronouns, and I'm our Ombudsman's Program Director. And thank you for having us today.
Thanks, Anna. We can go to the next slide. So I think many of you may already know about us and our work, but we're going to just incorporate a little overview just to be sure. And I have the chat open so I can see some of the comments, and we're glad to be with you. If there are questions people have, we're totally interruptible, so please raise your hand if you want to clarify or ask. And if we miss something in the chat, please don't hesitate to flag us. But we'll try to sort of move through the presentation and make sure we are timely so there's room for question, answers, and discussion afterwards. So we often get this question, what is an ombuds? And we stole this tagline from the city of Portland because it's so great. Funny name, serious work. But essentially it means that we are advocates for those members that we serve on the Oregon Health Plan. The term was invented in Sweden in the 1800s, and it was designed to mean a representative of the people within government whom that government is intended to serve. And recently I was reading a piece of work that somebody wrote about ombuds, and it turns out that in the 7th century, the Caliph of Islam advised the governor of Egypt, and I just love this quote, "Out of the hours of your work, fix a time for complaints and for those who want to approach you with their grievances." And I thought that really kind of encapsulates a lot of what we do, as does, I think we all particularly feel this one in Amharic, because there are ombuds offices all around the world. The term that they use for ombuds translates to mean the keeper of the people's tears, which we often feel in our work, as I know that you all often do in yours. But in English, it means that we are here to help. There are a variety of different kinds of ombuds, and we feel very fortunate to be called as advocate ombuds, meaning that we investigate with a small I. We don't have investigative powers the way, for example, our licensing department at the Health Authority does, but we do receive members' complaints and investigate to understand what's going on. But then we have the additional blessing and benefit of being able to say, what is it that you need and how can we help you get it? And in addition, even if we can't help them to get it, to help elevate their voices, to shine a light on where policies and processes may not be serving them. We'll talk a little bit more about that in a moment. And I'm going to hand it to my colleague, Brooke, who's going to talk about our origins.
All right, thank you. How did OHA come to have an ombuds office? Well, our team was actually formed in 2019 as a result of enabling legislation and is statutorily mandated to serve as advocates, as Kate mentioned, for those eligible for or receiving Medicaid-funded services. In other words, everyone on OHP is our population of focus. Our scope, a little bit about our scope. As I mentioned, we are called in legislation, and that's ORS 414.712 to provide our services for Oregon Medicaid recipients. And we shall serve as that advocate whenever there are concerns about access to, quality of, or limitations on care. And that is the key focus of our casework and what we focus on. Another aspect of our role and our job is to make recommendations to OHA for improving access to and quality of care. And so, as Kate mentioned, as advocates, we really do have twin mandates. The first is case resolution for OHP members, and the second is the elevation of member voice to improve policy and processes. And we do that by really elevating voice through stories and our data and share those recommendations to help foster improvement in policy and process across OHA. A couple other noteworthy elements is we are under the OHA's director supervision and control, but we do report to the governor and to the Oregon Health Policy Board quarterly about the services that we provided, about recommendations of improvement of our services, and recommendations about the issues of access to or limitations on quality of care that we're seeing. Next slide, please. And so we serve everyone, as I mentioned on the Oregon Health Plan, almost 1.5 million people. We have 9 full-time ombuds, 6 permanent. Of those permanent, we have 3 senior ombuds on our team. We have 3 people on rotation currently on our team. We recently just got an intake specialist. We have a principal ombuds and our manager, Sarah, to serve these OHP members. We average around 40 to 50 cases each month, some of which we're able to close really quickly, some of which we really can carry for weeks and or sometimes months, which is rare, but it does happen. We have a variety of team members on our team with different backgrounds, some that speak English and Spanish, Vietnamese and Japanese. We access translation services as needed, and we continue to build our team in a way that reflects the composition of OHA's priority populations. We serve all cases, and each of us has a particular content knowledge that we use to function as a lead or subject matter for instance, Kate focuses on children's behavioral health. We also have another senior ombuds, Libby Raskan, who focuses on adult behavioral health. Jaime Nino on our team is also a senior ombuds, and he is really an expert in overall Medicaid knowledge. And so my role as OHA's principal ombuds is really to, along with Sarah and the rest of the team, is just really being responsible for developing policy, program, and administrative improvements that address these identified urgent and emergent system barriers that come to us. Next slide, please. So we always, I think my light just went off. I'm in a new room, so sorry. Anyway, there we go. Light on. We always strive to center equity. Our process is culturally and linguistically appropriate and accessible and includes options that are really easy to find and easy to use. And that prioritization is in alignment with OHA's goal to eliminate health inequities by 2030. Our recommendations seek to prioritize health equity for all of our OHP members. And our values really recognize and center the needs and expectations of people in Oregon. We engage people in the solution, listen to, and act upon their concerns. We truly believe that client voice is essential for healthcare transformation. And as part of OHA's commitment to eliminating health inequities and co-creating with the community, it really is essential, and we believe this full-heartedly, for OHA as an agency to hear and listen to individual members' concerns. Next slide, please. And so, as I mentioned, our number one mandate always is case advocacy. And so, how do cases actually come to us? OHP members often come to us themselves, or their family members call on their behalf. We have providers call us, or families refer to us. Community members contact us. Other state agency staff, including yourselves, OHA, DHS, Department of Education, care coordinators, medical directors, and legislators actually call us too. And so I also just really want to make a note too that if we're not working directly with members, we do and will need a release of information. And I'm going to pass this on to Sarah to talk a little bit about what sort of cases come to us.
Thanks. And as I do, I just want to double check with if there's any questions too along the way so far. We can want to have discussion time with you at the end, but also happy to have conversation along the way. So it's an invitation to jump in with us as we go along. And actually, with that, I actually would love to see if anyone is willing to read this first story that is a member case that came to us and thinking about what an ask looks like when someone asks for our help. Does anyone want to just read that out loud?
I can do it. I always make the same request in my meetings, so I will step up. The first story is that my 4-year-old has complex medical care needs, and our CCO keeps denying the doctor's recommendations for tests and medications. I'm concerned they are not following EPSDT guidelines.
Thanks. And I'll just spell out EPSDT is early periodic screening. Oh no, someone help me with D, and then treatment.
Diagnosis.
Thank you.
Diagnostic,
and
yeah.
treatment. Thank you. Does anyone want to read the next query that came to our office?
I can do it because you all love my English accent. My daughter and I are Black and cannot find a therapist for her in the CCO network that meets our cultural needs.
Thanks, Hillary. And then someone else, if anyone wants to read this last one.
I'd love to read it.
Thanks, Shaylis.
My child has both developmental disability and mental health needs and is in the ED, emergency department, in crisis right now. But we have been denied entry at all inpatient facilities. We can't keep him safely in our home.
Thank you so much. And I do want to know, these are children's stories that come to us, not stories, but ask of people, Oregon Health Plan members who have sought to access the care on the Oregon Health Plan and encounter barriers. So this is really representative of so many of the stories that we hear from children and families, particularly. I do want to note we also really hear stories and experiences from Oregon Health Plan members across the range of Oregon Health Plan services and age categories and life categories as well, from dual Medicaid, Medicare individuals seeking to access pharmacy benefits and intersection there to Oregon Health Plan members seeking to use non-emergency medical transportation to get their care, or particularly we often see also challenges with accessing specialty care and getting that. So I want to say these are examples from children, and we see these stories across our program from Oregon Health Plan members. Well, with that, what do we do as ombuds? And where do we go when we hear a member's voice and experience? If we go to the next slide, we employ a variety of skills research investigation, and really start by working directly with the Oregon Health Plan member, or in the case of a child, their parent or representative, to understand what their needs are and how we can best support. Often that support looks like connection to the CCO, but we provide a variety of tools. So for this first one, we might say, would you like me to connect your plan for you and help you file a grievance that maybe EPSDT benefits aren't being applied, or the complex care needs aren't being met. We also may say this may violate your child's rights under EPSDT. We're not applying the clinical determination of that as OMSPAs, but we can flag and ask to make sure everything is fully considered for that. And to do that, we both do that with the CCO, and then ensure that, particularly if a service has been formally denied, that the member has the tools to ensure that their full rights are upheld, to file a to request a denial of that, or if that's been denied, to go to hearing. So education rights, ensuring rights are upheld, and then flagging that for systems impact as well. We might also say, would you like me to connect you to a care coordinator who can help you find providers in the network? And start there, reconnecting and helping to involve the coordinated care organization in finding a solution, or self-identifying as a coordinated care organization, that what this member says is absolutely true. How can you, as a coordinated care organization, think about that to provide, in this instance, culturally responsive care? It could be also linguistically responsive care. And how do we partner to solve that and identify what this member says is something that should be thought about for this member and as a larger systems issue on the CC level? We may also just say, I can work together with your care coordinator and other folks who could help us with these barriers to make sure you get what is needed. And really, we try to be member driven, and we have Oregon Health Plan members who will come to us and want to be involved in every step of the process and do that full partnership. We seek to really listen to that. And other times, I'd say not particularly, but we will experience with children and families where parents may say, I am exhausted. Please move forward without me, with my permission to act on my behalf in that advocacy. So we really try to be centered and understand and bring those dots and connections together. We often find working with a care coordinator and asking that care coordinator to come back to the OMSAS program to let us know what's going on, or help us bring us in. We give open invitation to the member and the care coordinator to either can always bring us back in as an OMSPA's program if something's not working out. But we often find re-engaging the coordinating care organization, restating from an OMSPA's perspective why things have not worked out for the member, and that re-ask helps to have a new connection that, in not all cases, but in many, can help with the outcome and really help to get that care met.
Sarah?
Yes.
So you kind of mentioned it, but I just want to double check my understanding. So what I think I'm picking up is that you're primarily talking to care coordinators at the CCOs themselves, the coordinated care organizations. Is that accurate, or are you also working with other types of care coordinators?
Yeah, we're working sometimes directly with care coordinators. We work primarily, but not exclusively, with coordinated care organizations at multiple points. So it could be from asking their network coordinator to really report back to us on, is this member experience that indicates a gap in mental health network adequacy for culturally responsive services, a unique experience? So we start by asking to solve for that member, and then we would ask, oh, you solved it for that member, but was that something that should have been solved beforehand, or do you need to make any adjustments and changes? So depending on the need, we'll work with a variety of contacts, primarily with coordinating care organizations. Providers will also reach out to us, as Brooke referenced, and we will work with that provider when they're coming on behalf of a OHP member, access to care or quality of care concern, and understand that and sometimes help as that bridge as well. So great question. Adding from Kate in chat, and in the case of the youth in RAP, we often work with a RAP care coordinator who is delegated by the coordinating care organization. So depends on what the unique circumstance is. We do primarily work with CCOs, but we employ that broad authority to work across entities where there is somebody touching the Oregon Health Plan. And that includes with internal Oregon Health Authority staff, with Oregon Department of Human Services staff, and sometimes we even bring in like people to the table together to where that table has not already been existed. I think also as our goal as the OMSIS program is where we are needed or the pieces aren't in place, we jump in and provide support until those are in place. Then we pull back out because we aren't care coordinators. But when those places and tables are already set, we check in with the member and those at the table to see if there's additional advocacy support or OMSIS perspective that might benefit from us being there. And sometimes we'll hear from the member of, yes, I really want you there. Or sometimes we'll hear like, I think I'm okay, but I'll come back to you. So we really do try to hear from the members as well. And then also note from Kate, in the case of highly escalated cases, youth, board, and emergency departments, we attend or convene the high-level staffing to foster immediate solutions as possible. So when there's a 5 p.m., like let's solve this together, we will jump in. And even those, I will say, we know are best solved when we immediately loop in and partner with our coordinated care organizations. We have those expectations for CCOs to do a lot of that work. And so whenever possible, that work is still done best with the CCO fully at the table. Yeah, Remy.
Hi, Sarah. My name's Remy Watts. I use she, her pronouns. I'm from the Oregon Department of Education. And I was just wondering if OHA ombuds ever interact with like school Medicaid claims by chance, if that's something that comes across your desk at all.
It hasn't largely. I've often been curious about that and happy to follow up offline with you or with, Kate and you. Actually, as a parent of two children that receive IEP and 504 services, who's asked to sign the form for Medicaid billing, I often know I'm personally curious of like, how does this intersect and fall behind the scenes? But because the OMSIS program is really directly for the access to care and quality of care and not a billing concerns, we see less of that. We definitely have seen complex youth, and actually the youth who's highlighted and spotlighted, and Kate can speak to this really beautifully, in our 2023 report, which we shared that youth story with their full permission. And when we presented that youth story, when Kate presented that to the Oregon Health Policy Board, the youth was on camera with all their friends and family to hear their story told. I think that's an example where there was gaps in school-based services that led to some of the pieces, but it wasn't the reason why someone came to us. So because it's often billing, but I'd be curious to explore that more. So really good question.
Interesting. Thank you.
Let's go on to the next slide. I can tell these are like what looks like in the details is really helpful for this group. So let's keep this conversation going. We do really seek to separate out that individual need from systems improvement. Sometimes those can't be separated, but what we often have found is when I say this member needs help, XYZ, and this policy is broken, no one knows what to solve or how to do it. And so when we're able to say, let's solve for this youth or this family or this non-emergency medical transportation need, or look at why there has been a denial of a service for a child when we think EPSDT should have been applied. When we're able to solve for that, meet that individual's need, our work as an OMSIS program is not done. But we want to first meet that need. What we then do, and we oftentimes do this along the way, but not intersecting the two when possible, is really think with taking the EPSDT examples of a denial of service. We really make sure that if there's additional communication or education needed for providers, we follow up with our internal EPSDT team to make sure that we're getting additional talking points in our education. If there's the CCO, the coordinating current organization needing to apply policies differently, we make sure that that is again addressed either through technical assistance, further overview, and also make sure that individual, and then we will raise things for further formal recommendations when needed. The majority of our work, I would say 90 to 95% of our systems improvement occur behind the scenes. And we're able to, from individual cases, take those learnings and so often make improvements for many others that often is unseen and invisible. And that's okay. We know that when members come to us, oftentimes, because we're a funny name, we're a state agency, you got to know a little bit to get a hold of us. We often find members come because they have a high degree of self-determination and self-autonomy and a deep sense of work equipping the state to make things better, not only for themselves, but for others. So members who come to us in many cases maybe could have solved this by themselves, but they realize, in the case of one person that our ombuds worked with until I think 7 p.m. last Thursday night, and then I'm still like working with today to arrange non-emergency medical transportation for a child where EPSDT criteria hadn't been correctly applied. Those parents, those individuals know that their experience reflects the experience of many others. And so they come to us to bring advocacy by asking for help with their case so that others likewise, so that the state understands that barrier, we understand and learn from that and act to change things as a system. So that's one of the things I find most humbling from those who come to share their stories with us. Yeah, Anna.
So I don't know, maybe everybody in here does know, but when you say when EPSDT criteria hasn't been correctly applied, Sarah, can you, for those of us who don't speak Medicaid, what does that mean?
Yeah, and I might need to crowdsource this a little bit, but let me
Feel free
see.
to call on a friend to help you.
Well, and I just referenced a child who had was at, has a genetic condition from birth who needs to go to Seattle Children's. We actually have quite a few cases like this because it sounds like 5 other cases, the one from last week of children with complex genetic disorders that there are no specialty providers in Oregon who have specialties to treat that complex genetic disorder. And there's Seattle Children's or maybe a hospital in Texas or on the East Coast. And those are really identified as the only providers where there are specialists in that. Oregon has a Medicaid responsibility to always provide the most fiscally responsible care. So it does make sense that a coordinating care organization will say, you need to go to OHSU, Oregon Health and Science University, or Dornbeckers. We have a specialty children's hospital in the state. That is a fiscally responsible thing that we want our coordinating care organizations to do. The gap that falls through is if the second question, and again, I can crowdsource to get help because I'm not explaining this in a technical way, is if you say, is there a medical condition for this child that the treatment can only needs to be given at, and are we providing that right treatment? So in this examples of these complex ones, the treatment needs to be at Seattle because that's the only provider. But that's a complex, you need to have a conversation and additional review. And thanks, Remy and Kate are crowdsourcing in chat. So thank you. Remy, EPSDT will cover treatment for anything necessary, and it's only until youth are 18. There's also a way for kids up to 26 to get EPSDT level coverage called Young Adults with Special Healthcare Needs. So another topical area. And then from Kate, often with EPSDT cases, we see chairside denials where the doctor won't submit a referral because it won't be approved. So that's a challenge where we'll also see member rights aren't upheld. Oh, and thanks for clarifying, Kate, that the current standard is medically necessary and medically appropriate until 21. So whole bunch of deep dive, and this is I think, especially this is a policy committee, like if that's this particular area you want to dive into more, like I suspect that, we see that in a lot of our ombuds cases and can also think through that as well. So thank you for that crowdsourcing. Anything else to add that I missed there?
No, I think that's helpful.
Yeah. I talked to, and we go to this next slide, I touched on 95%, if not more, of our system change work. We really don't end up talking about anywhere because it just gets done. We hear from members, we make the adjustments with our Medicaid partners, or maybe a procedural change at the coordinating care organization, and we move on. We do have this formal reporting requirement. When recommendations rise to the level of being included in our formal reports, they often represent long-standing systemic barriers that need significant agency prioritization, policy change, or we just haven't chosen to prioritize something and we continue to hear time and time again about a concern. I think that mental health network adequacy for youth is an example of an ongoing theme that we hear time and time again. We do have all these on our website, and we also track from our reports and work collaboratively with Medicaid. Medicaid provides updates on progress made for those reports. They're not formal audits, but the team that responds to and tracks agency responsiveness for formal audits also tracks and reports on our reports. And we did that early in the program because we realized we were issuing these reports and there is this reporting requirement, but then we needed an agency accountability mechanisms to say, let's give regular agency updates to track what progress is being made towards ombudsman's recommendations or not. Because many of those are very large scale systems issues, we do see that takes sometimes up to 5 years to begin to see that true policy shift. But we do see that over time. I've kept on talking a lot. I want to move us along because Kate's going to actually talk about some of those specific kids' recommendations. So this next slide, I'll pop into chat where you can see a particular children's mental health report that Kate's going to dive into more. But with that, let's go to the next slide and I will hand this back to Kate because this is, I think, some of the meat that you'll all be interested in as well.
There we go. There's the mute button. Okay, thank you so much. And just a quick time check, Anna, for where you all are in your meeting. When would you like to see us wrap our slides? Because we want to make sure there's plenty of time for you all.
If we're doing sort of like dialogue and slides at the same time, we just want this sort of whole section to be done by 4. I was just responding to you, but I didn't want to cover the slides to do so.
Okay, thank you. We're actually getting kind of close to the end, and I think it'll move us naturally into conversation. So thank you. As you've heard from Sarah, we really collect data on all of our cases. We disaggregate that data, we anonymize it, and we use it to drive our reporting. We are required by statute to report to the governor's office, our own Oregon Health Authority Director, and the Oregon Health Policy Board in writing at a minimum quarterly, and we use our annual and sometimes our semi-annual reports to really focus in on the themes that we are seeing and hearing from our members. Sometimes those themes are driven by volume. We know if we see a high number of a certain kind of cases, that tells us what's happening on the ground for our members, but we also know and really deeply value the fact that a single case can teach us a great deal about what is not going right in the system, particularly for children, youth, and families. We are so pleased to be able to say that our colleagues in the Medicaid division, and we're so appreciative of their work to do this, they have agreed to receive our reporting and treat our reports as an audit, and they document and track the agency's work around our report recommendations. And then all of our reports are available on our website. So I'm going to step into our children's mental health report that we issued. And I'll start by sharing that in 2022, we used our annual report by Sarah. Thank you for joining us. We know Sarah had to go on to yet another meeting. It's the life of a manager. But in 2022, we utilized our annual report to report out on adult access to behavioral health care services. And my own background is with children and child and family mental health for several decades. And I'm often the person in the back of the room, as I know many of you are, who are saying, what about the children? And so Sarah was very kind and generous and said, great, go for it. Let's do it. So we used the second report of our year, our 6-month 2023 report, to issue a companion piece that looked at children's community-based mental health. And a huge shout out to our colleagues on the kids team who were just instrumental in helping us sort of shape this focus and also to inform it so that our reporting is ideally as accurate and as informed as it can be. So Hillary, you were just essential here. Chelsea and Jesse in helping to look at review, rewrite, Brian Pitkin, Beth Holloman about some of the programs that we focused on. So enormous thanks to the kids team who do this work all the time, as do you, our members of our System of Care Advisory Council. So in our 2023 report, you know, we work often these cases where youth are boarded in emergency departments and there are no beds available. And we know that there aren't sufficient beds to meet the needs of the children and youth in that kind of crisis. But we also didn't want to issue a report that called for more beds. So we don't dispute it, and we wanted to use the report as an opportunity to ask the question, what could be strengthened in the community that would prevent children and youth from escalating to that level of crisis in the first place? So we used that question to help us focus our report. And we looked at both programmatic and service level recommendations and also system level recommendations. And we issued approximately 8 of them. I'm just going to walk us through what the 8 of them are. Given the work that you all do, I think this will be familiar to you. And then I'm just going to offer a few notes about what has changed since 2023. So I'll just walk through them, and please jump in, ask questions for clarification as you like. The first recommendation that we issued, and we did this for all ages, was we issued that consideration be given to developing statewide networks, particularly for mental health services, because members come to us and say, I just changed CCOs and now I can't get the mental health that I need. I either can't see the provider that I was seeing, I have to go through an entire process of asking for continuity of care and being exempted, or I have to find a new provider. Or in the case of that story that the member shared with us, my daughter and I are Black. We have a Black therapist. There's 2 Black therapists in our region that we would like to see, who would be willing to see us, and they're not contracted with our CCO. So that was one of our first recommendations. The next one, we talked about prioritizing and leveraging funding and data, particularly the data specific to children. One of the questions that our former principal ombuds asked in the final year before she departed is, she said, Kate, how much money do we spend on kids versus adult mental health? And that proves to be a difficult question to answer for lots of reasons. But one of the reasons is we don't always do the best job that we could about breaking down utilization rates for data specific to adults versus children, and then children across different age brackets. And that really helps drive the second recommendation, which is how can we prioritize funding of community-based children's mental health service in a way that is more concomitant with the way in which we fund adult mental health services. And the language that we used was, we recommend that children's mental health services are funded at amounts equal to or greater than investments in adult mental health, and at least proportional to the number of young people in Oregon. So that was our second bucket. Our third is, we recommended development and implementation of culturally specific services within children's mental health. And in particular, I think we issued a recommendation about looking at how that is done in and after ED admits, knowing that children of color and AIAN, Alaska, Indian, and Native American children are seen at disproportionate rates in EDs. Fourth, we offered a recommendation to strengthen the peer workforce within children's mental health, something I know you are all familiar with and advocates for. Next slide, please. And these are the second half of our recommendations. These 3 will probably look very familiar to you. We really wanted to focus on sort of the middle of the continuum of care, the middle to upper end of continuum of care, what could and should be happening before a child or youth needs to go to the ER in crisis. So this was 3 years ago. MRSS, Mobile Response and Stabilization Services, was just coming online. So we issued some recommendations specifically for expediting access to MRSS across the state. Ditto, fully implementing IIBHT, intensive in-home behavioral health treatment services within all CCOs and across, in particular, our fee-for-service program. And third, we wanted particularly to highlight the importance of access to mental health respite care for children and youth, because we know there's a disparity there. Children and youth who are involved in child welfare, who have developmental disabilities, can access respite care. For youth who only have mental health challenges, they don't have the same level of access. And then finally, given the number and type of cases that we saw where youth had multiple system involvement, where families were traipsing around from state agency to state agency, or services and supports that emanate from different state agencies with different funding sources and different grievance sources and differing levels of advocacy. If you come through the OHA door and you're an OHP member, we're your advocates. If you come in through the Department of Ed, it's a different process. So given the sort of unevenness of the landscape in terms of what door the family comes through and what their needs are across those systems, we issued a recommendation that consideration be given for the development of an independent Office of Ombuds for Children and Youth in Oregon. So those are our recommendations. We are in the process of bringing those recommendations up to date because a lot has happened in the last 3 years since we issued them. So we're in process, so I don't have updates for you about all of them, but I can offer just a few updates and things to keep our eye on. And we're glad to come back as we finish evolving our update and report back to you about that if that's something you'd like. Regarding funding and data recommendations, I'll talk a little bit about this before we close, but we are in the Ombuds office seeing a trend of children presenting in the ER younger and younger with increased complexity, increased aggression. And so we're issuing an Ombuds spotlight about that, and I'm happy to forward that along for distribution to you all. I'm happy to say Senate Bill 846 was passed last session, and there are a number of folks at the Health Authority working on a report that will really better integrate and look at what do the data tell us about how our children are doing in Oregon. That report is due to the legislature in 2026, and we're supporting it. We're glad that that's going to come out, and I think that's going to help continue to clarify what the needs are. And then Oregon Pediatric Improvement Project, or OPIP, recently issued a series of recommendations, again, about data and funding specific to CCOs. And if you don't have access to that, I'm glad to share the link. Next slide. And I think this is our second to last. Regarding mental health respite, Anna, do you want to say, or Christy, do you want to say just a few words about where this is in process right now?
Sure, I can step in there. Basically what the slide says is we're in conversations with the Medicaid division. I know there's a Medicaid specific term. The more I work with Medicaid, the more I learn. It is its whole language unto itself. So I don't know if they're recertifying or something, the 1115 waiver, and there is a possibility that that waiver could include some expanded access to respite. It is a complicated conversation. We have to figure out how to give them the right language to use to go seek that approval. And so that is what sort of we're trying to figure out in OHA. Lots of folks from within OHA are helping try to figure out how to put the right words on paper so that they can go ask for permission to expand access to respite via Medicaid.
Absolutely. And thanks to Christy for sharing the NASHP, I'm not going to get the letters, National Association for State Health Programs, Policies, that featured what other states have done using their Medicaid waiver to fund respite for youth. So that was great to be able to kind of continue to advocate for. And then the very last piece is we continue to believe that the addition of an Office of the Child Advocate or a child-specific cross-system ombuds would be useful. We have updated that recommendation. We had previously issued the recommendation that it be housed in the governor's office, and we now recommend that it be housed independently with oversight from a board. And then I think our very last slide is really just to highlight a few things very briefly that have also transpired since 2023. We've talked a little bit about EPSDT implementation. I love the comments in the chat. I think that was Rami who said, but there is no limit. There's no line. The limit does not exist. I love that. So we do monitor EPSDT challenges to implementation because there's still a learning curve taking place. I can answer questions about that. We did have a case this winter of a family who whose child needed behavioral rehabilitation services, BRS, and was unable to get that without engagement with child welfare for the last 3 years, and have experienced some substantial impact to their family as a result. We continue to advocate for access to BRS without needing to engage with child welfare or OIA. I mentioned this, we are seeing younger children in crisis. I think it's worth just pausing for a moment to say what drove my desire to issue this spotlight is I realized in January that typically when we see these emergency department boarding cases, youth are, 14, 17, sometimes 13. In January, of 5 of our most complicated cases, 3 of them were age 10 and 2 of them were age 10 and 3 of them were age 8. So that was distressing to see, and I'll share that spotlight. On a positive note, I do want to say in the last year that the Oregon Health Authority has developed a child, youth, and family governance group and tasked one of our senior health policy child advisors with running that in our health policy and analytics division. And they are convening managers and leaders from across our divisions with the idea of developing a statewide plan for child and family well-being. So I'm excited to see that that's happening. And I think it's becoming a good vehicle for cross-divisional conversations about how do we define child and youth and family health, and how can we put together a joint plan to help make that happen. So I'm happy to pause there and take questions, and I'll look in the chat and please sing out.
I don't know that there's questions in the chat. I think there's some folks adding some context and nuance to the topics that you were naming, Kate. So Remy's mentioning that Medicaid waivers, they have to reapply every few years to maintain the permissions associated with each different waiver that we have. And then Selby's mentioning that the Tri-County System of Care recently had a community report. I don't know if that's a written report, Selby, or a conversation about an 8-year-old that was boarded in an emergency department for a week. I'm not sure if there's more you'd want to say about that.
No, it was just our standard barrier submission process. I was just trying to use more generic language to describe. We had heard from a community member registering a barrier for us to look at and triage. Got you. Okay. And Remy, you're the other comment, but you've got your hand up. So what would you like to say?
I mean, I always have my hand up. I was just wondering, so a lot of my work, for context, is infusing community health into the K-12 system. Because one of the things that schools have that no other agency or system has are the kids that we're trying to serve walking into the door every single day. And schools are a huge a community prevention space. And my job is to help schools lean into that. And I was just wondering if there were any very specific call outs within the recommendations of how schools can be involved or more involved, and how it is also I'm noting for also additional context, it's much easier for OHA to get CCOs to engage with school districts than it is for me to get school districts to engage with CCOs. There's a lot of local control in our K-12 system, and it makes it very difficult to elevate statewide best practices. I won't get into details, but it's changing a little bit. But anyway, that's all to say. You know, schools are eager partners, and I'd love to hear more about how they are being recommended in community health strategies.
So, Remy, I'm going to step in, Kate.
Sorry.
Because, no, totally fine. I just want to, so, this committee is really trying to prioritize sort of one high acuity space activity and one more community-based activity. And we're doing more work on the access to behavioral health and disability supports in schools, that we're actually going out and doing a focus group with impacted youth and families, that we're going to bring that information to this room to have that conversation with like more lived experience voice infused in it. And so we're out gathering that lived experience perspective right now. That will come here, Remy, but I don't want us to have that conversation yet without anchoring ourselves in that sort of, this is the intent, to anchor ourselves in what the ombuds team had dealt with. And then we're going to dig in on sort of that parent voice, youth voice conversation around schools in a couple months. So not to say we can't talk about it, just there's going to be a lot more layers of context to bring into that conversation very soon. So, Kate, I don't know if there's more you'd want to say, but I just wanted to put that caveat.
Two things, Remy, if you'd like to, I don't know, I think Remy said they are getting ready to transfer to the phone, so I could put this in the chat too. But if you're still here, Remy, totally happy to connect with you offline if you want to have a follow-up conversation. And one of the things that we are working on is increasing our outreach to schools so that families, youth, school counselors, teachers know about us and can recommend us as a resource. So raising awareness about that would be, and I'll put how to reach us in the chat too. But happy, and I'll put my information in the chat if you want to IM me or email, we can talk further.
And Molly, I see you're off mute. Was there anything you were going to say, or are you just randomly off mute? Oh, you're off mute because you have a different audio. Gotcha.
Yeah.
Courtney.
All good. All good. Keep going.
Yeah, I just wanted to say one thing. I was just thinking about, again, your role, but also, so I'm Courtney Esparza, the Behavioral Health Director at Trillium Community Health Plan. And one thing that we've just met recently and talked about, like we hardly have any member grievances, which is odd, right? Like for a plan. Yeah, like people, like and honestly, like we try to encourage, right? Because that is a way to hear and to, again, to your point, you resolve any kind of situations or conflicts. So I just thought I'd throw that out there. It's interesting. Someone said there's kind of a culture that, especially in behavioral health, that more people maybe are encouraged just to tell their providers about it, or I'm not sure how we've ended up in that, but I will say, just again, from a CCO, I guess I can't speak for all the CCOs. Maybe they don't want to encourage grievances, but I know we at Trillium do want to encourage members to reach out to us if they feel like something is not going on, so that we have that opportunity sometimes to maybe do something even before it comes to you all. So I just want to throw that out. I thought that, and literally this just had this conversation last week and thought it was very interesting, and I was surprised by it. So
thank you, Courtney. I mean, maybe I could just say, ideally, maybe it means that you're doing things really well by your members. I mean, that's like, assume the positive, right?
Right.
But, we often wonder about member awareness, because in relative terms, we're still kind of a new team. We've been around for like 7 years now, but then COVID hit. It's just created a lot of delays, and we don't have a lot of margin to go around and raise awareness. Like 80% of our time is spent on the casework itself. And as Sarah said, or Brooke said, we just got an intake coordinator last year. Like, yay. So we sort of like, we all wash the dishes, we all take out the trash, we all try to round with people. But if you think that raising awareness of both our office and your, the plans, a willingness to receive complaints and grievances, one area that we sometimes have presented at is the Community Advisory Council, the CAC. And if you wanted to invite us to come, we'd be glad to do maybe even like a joint presentation, because often what we say is, sometimes when members contact us, we say, have you talked to your member, not to make to your plan, not to make them jump through another hoop, but more to say, hey, does your plan know you need help? they want to help. So we try not to triangulate in that sense. One of our first acts is to say, how do we get you better connected back to your CCO? So we'd be glad to do that with you if that would be something you'd be interested in.
Yeah, yeah, I will definitely. Let me connect with you offline because I think that would be, again, we just like to encourage just to make sure, like you said, that members know the avenues they have, and that they're not just left out there
Yeah.
on their own.
Yeah, for sure. Let's see. And Alex, I'm reading. I hope the 1115 waiver articulates and lowers criteria on what kind of organization can provide respite. There's friction between the liability of housing youth and administrative burden between mandated certification, license, regulatory mandates. If only mental health orgs are to provide respite, absolutely. The value prop is low and therefore the intent of building a network may or may not happen. That is one of the complications I know that we were really educated about when we issued this recommendation about respite, that those are exactly the tensions that you're naming, Alex, that come into play, that those informal networks are harder for Medicaid to figure out how to fit into the requirements. So we absolutely endorse that it exists at formal and informal levels. Let's see. And Leah, I think you have a question in the chat. How much, if any, coordination do we have with other ombuds offices programs? I could just say just briefly to that, Leah, we are actually increasing that coordination as we speak. We are all aware of each other as ombuds offices, and when folks come to us, and for example, if there are youth with developmental disabilities and they're in residential settings, we dial up Leslie Sutton at the residential facilities ombuds and engage them. Sometimes we co-staff, sometimes we refer. We often refer to our governance advocacy office colleagues who are ombuds on the ODHS side. And we're actually in the process, and Brooke is helping to lead this, of standing up a statewide ombuds network where we're better connected and we can better facilitate those cross-system referrals. I hope that's helpful answer to your question.
Yes.
Okay. All right. And Debbie, it looks like you have your hand up.
Yeah, and this may be not specifically at all for the ombuds office, but just thinking when I was reading over the report, one of the reports that was attached to the meeting material, and I was thinking, Anna, when you're talking about acuity and high acuity needs, and one of the things is, so I'm from the youth authority, so I kind of look at it from that lens. And one of the things that was mentioned is that sometimes when youth aren't able to get the services they need in the community, they end up being escalated into other systems. And ours is definitely one of those systems where we are receiving youth that are probably best served in either in home in the right settings or in other systems that are better equipped to provide the mental health services they need.
Yeah.
And I'm just wondering and thinking about any kind of return on investment that has been done, a calculation of like, hey, like some of the programs that were mentioned, like, I can't remember the acronym. It was like intensive in home something.
Yes.
IIDHTA.
Yes, the whole thing.
So many letters.
Yeah, and just like, oh, what's the cost of that versus what's the cost of a bed if a kid comes to our facility? What's the daily cost and anticipated length of stay? So I just wonder, like Anna, and again, I think this was a bigger picture question, so not just for ombuds, but while I was thinking about it, I wanted to say it that that's another way to demonstrate, like, yes, this does seem like an expensive price tag, maybe for funders, like, do we have the money? But well, look where that you're gonna spend the money at a much higher rate if we don't have them at this level. So anyway.
So Debbie, I think that's a really great point. And you know, the point of having the ombuds come in and sort of share this report with us was to help us really think about where would we want to be prioritizing our efforts and energies around something at the high acuity end. Is it that we want to say, we're going to put our thumb on the scale for ensuring that everybody has access to their EPSDT benefits that they're entitled to, which means that everybody gets early periodic screening diagnosis and the medically necessary and appropriate treatment that screening and diagnosis indicates, right? That is addresses some high acuity needs, but also some lower acuity needs, right? Depending on whatever the screening or diagnosis is.
Yeah.
Or is it in-home intensive behavioral health care treatment? I don't think it makes sense for us to say we want to focus on measuring beds or we want to focus on measuring emergency room boarding because we've sort of like lost the plot at that point. Like that's measuring our failures rather than measuring something that helps us prevent those beds from being needed, right? So I don't know what the answer is, Debbie. I think
Yeah.
those two are the two that feel most fruitful to me is
Mhm.
the early periodic screening, diagnosis, and treatment, or the in-home intensive behavioral health.
Mhm.
And EPSDT might lead to IIBHT, right? But if we have to just sort of say, as a system, we're gonna really dig in and say we got to solve this problem, we might need to just focus on one thing in this room and really push and pull on that one thing for the next session, especially as things get chaotic around HR1. Ebony?
And Jesse, help me out, or if you are like, no, Ebony, you're overcomplicating, please say so. But I appreciate what you said, Debbie, because I definitely, kind of see the through lines and understand that, if we had the right kind of levels of care and the right access, then, my assumption is that we would then see, less admissions or recidivism into, some of these other systems that we don't want to see our young people in. And I think where my head goes to is like, how do we make sure that as we take this process from an iterative approach, because it's very complex, how do we make sure that we are informed enough to also be making the right recommendation in terms of what we want to prioritize? Because where my mind goes is it's like, what percentage of youth, let's say, that landed in OYA, needed a residential level of care, psychiatric, level of care, or whether it was IIBHT or whether it was, something else, just so that then we're working towards the right solutions. Because sometimes, and I, don't know how to validate this, but I have a belief that there are some missing services within our continuum. And, again, I think it's just, how do we be mindful of, how do we make an informed decision so that then what we do recommend that then results in, additional funding and additional capacity has the impact that we're looking for. And, I do know that there are youth, in temp lodging and OIA that I'm a believer that, yeah, if they had the right level of behavioral health support, they wouldn't be there. So I do recognize that too.
Yeah. And we're just one very small piece of this pie. I realize, for sure we're one small piece of the pie, thankfully. And we've got, close to, well, we have 3 units, so probably close to 50-ish youth that we consider our specialized care units that have complex mental health needs. So we could definitely kind of do some qualitative analysis of just the kids that we have right now to say what was the trajectory that got them there and where can we identify some missing pieces. Just might be something interesting that we could do. Just to kind of tell that story of like, where are some gaps just in the kids that got into our system. That is by far, I understand, not all of the examples, but just bringing my little piece to it.
I think to answer your question, Ebony, I think my thought is it's hard to know sometimes where the missing parts of the system are, because even the parts of the system that we have that are supposed to be in place aren't in place. And so our continuum, like the parts of the continuum that are supposed to be there are missing. So like IIBHT is meant to be a place where there is a community support that is unique and is a kind of a menu of services that families can choose from to meet their needs, and in theory would be the support that would be available to keep young people in their communities, help support them from needing residential, from needing or from ending up in, in juvenile justice. And without it, I think what we're seeing is that, people do end up in residential, or they don't have a place to land when they are ready to come home from those intense services. And without that, it's hard to even know where the missing places are, because if we don't have that in place, then we can't even see where the other missing holes are. And Alex is being very patient with his hand up, so I'll stop talking.
Oh, well, Jesse, you took my win because I very much
Aha.
in line with exactly everything you
Perfect.
said.
I love
Was
when you
my-
and I are on the same page, Alex.
Yeah. Hey, and I think just like a few perspectives that I would say on top of that is it's overwhelming sometimes how many offers there are in the behavioral health space for youth and children. And just to really point to Jesse's avocation on that piece is where's the friction on the access to those? IIHBT is a great service. Is it being accessed to the levels that we want? Have we ran through cases that have kids housed in the ER for whatever amount of time and figured out where they could have accessed these different programs? What could have helped prevent that, and why didn't they access, and have that retrospective to really understand where the friction in the system is from performing at the scale it needs, or if we have too many of these services that overcomplicate the system. And then the other piece as to housing and residential that I always dealt with for years was the psychiatric residential system and the treatment of the youth, and having that place where these youth need to land. And in many circumstances, the youth in the Oregon Youth Authority and child welfare system don't have that place to land, but the system's so rigid, it doesn't identify a different treatment path for a youth who is essentially homeless. And so we're continuing to apply one solution, one paradigm, is this treatment is only successful if you have a place to go afterwards. And that's not the reality and never will be the reality of those cross-system youth. So really looking at just paradigm shifts in the system about how treatment's applied for those high acuity youth.
Thanks, Alex. It is 4:15, or actually 4:16. And that is the time in our agenda that is set aside for public comment. It looks like everybody in this room is a member of the committee or acting as a proxy for a member of this committee, but in case I am not noticing you and you are a member of the public, would you please raise your little Zoom hand or your actual physical hand and speak up if you are here to say a thing to us? All right, well, that was long enough. Awkward pause. Someone probably would have spoken up during that time. So we now have 13 minutes left. I do want to just follow up on the school-based services piece. Will be next week or next month, that we'll be bringing some more information, research that we've been doing, both around policy and program out in the world, and also with lived experience in our sort of the affinity spaces that we host. So we'll talk about sort of that more low acuity space, and then we kind of need to figure out, okay, what is this committee going to hold ourselves to trying to accomplish? So are we going to focus really on in-home intensive behavioral health treatment, and to Alex Salas's point, what happens if you don't have a home? Is that if we were digging in on that, are we creating opportunities for young folks who don't live in a family home or live in a safe family home to have access to the same types and levels of care? Are we going to focus on the early periodic screening, diagnosis, and treatment benefit, and ensuring that folks have that, and ways to use that? So if we pick a thing, then we have to figure out, okay, what does that mean? How then do we dig in on that thing, right? If we just say like, oh, we want to shout about EPSDT all day long to everybody, that may not make much of a difference, right? But if we have a strategy we want to pursue, and the ombuds team is pursuing it, and the council is pursuing it, maybe we can build some economy of scale there and see if we can really make some movement, even as we're moving into an environment in the 2027 session where I think we're going to be seeing funding cuts, sort of even, regardless of what happens in November. I had someone chat me today and be like, oh, but, big blue wave in November, maybe we won't see HR1 funding cuts come through. I don't think that's realistic. I think we should be planning for what we see coming for HR1. And we will be having, just so you know, a report at the full council meeting on June 2nd, about the impacts of HR1, or what some folks call the Big Beautiful Bill, and how we anticipate that impacting access to services and programs in Oregon. So if you are hearing HR1 stuff and not sure what that means or what that might mean for us here in the state, we'll have a short discussion about that. The Oregon Health Authority and the Oregon Department of Child Welfare, I know, have hosted webinars as well, really trying to preview what they're seeing in these cuts and how they're going to be impacting. So we're going to be responding to funding cuts and program cuts over the next year. And so figuring out what do we do in terms of how can we continue to improve access to care while care itself is being cut might seem like an impossible question to ask, and also I think our jobs. So I don't know if there's more. I think the considerations that folks have named out already in this room have been really, really helpful. Also, I'm sorry, I'm in a hiring process and the HR team is chatting me. So if you keep hearing those little dings, that's my fault. But feel free, other folks, to chime in. I don't know, Jesse, if there's other stuff that your team would want to say. Kate kind of, okay, called on you a second ago, but then I talked over. So I don't know. If there's more for y'all to say, feel free. Otherwise, we can close up shop a little early. Kate, is there more that you wanted to hear from folks?
I'm happy to take any follow-up that anybody would like to with our office, either, further questions that you may have if you want us to return down the road, and or if there are things that you want us to be thinking about, attending to, advocating for. Our members coming to us to tell us what's wrong and what they need is the chief thing that drives us, drives our work, drives our reporting. So I guess with that, I would say two things. One, please don't hesitate to send families and youth in need to us, or ring us up yourself. I always say families can consult with us. They won't set anything into motion by coming to us. We follow our family's lead. So I know there's a lot of system mistrust historically and specifically right now. So people can just call us up and learn more about who we are. So please don't hesitate to put our information out there. And I guess I would like to just close by saying I started doing this system of care type of work, oh my God, over 10 years ago. Before there was a System of Care Advisory Council, and there were like 3 or 4 of us in a room trying to help move forward wraparound in system of care. And it's just such a joy and a delight to see all of the work that you all have achieved. I have your beautiful plan right here on my desk, which Anna brought to me, and I told her I read it in the sunlight away from the computer, like you do when you're reading something really important. It's right in front of you. So thank you so much for your work to make things better for Oregon's children, youth, and families. So grateful to you all.
And anyone else who wants a paper copy, let me know. They are available for download on the internet, but I have 2 boxes of them right behind me. I would be happy to, oh, Molly, I'll bring you one.
And it's reversible in Spanish and English, which is so cool.
We learned that from the Next Door Inc. in Hood River. All right, folks. Well, Chair Clark and, oh my God, Leah, what's your last name?
Tucker.
Chair Tucker. Do either of you have anything else you'd like to say, or shall I announce our next meeting and call it?
I don't have anything to add.
I don't either. Just thank you so much for all of that information. It was very helpful.
Oh, and we have our post-meeting survey link. So if you would please go ahead and fill this out. You have 7 minutes left of your time in this meeting. So go ahead and use that 7 minutes. I'll paste it in the chat if you just go ahead and click on that link. I see your hand up, Alicia. 1 second. The next meeting is June 24th from 3 to 4:30. We will be bringing in information about access to school-based services, access to the necessary assessments to get those school-based services, and some information about schools collaborating with community providers to ensure access to the appropriate services in the school. some of the opportunities and challenges that we have identified with all of that. And Alicia, what have you got for us?
I was just wondering, can you hear me okay? I'm sorry.
We totally can.
Okay, great. I'm wondering if those slides would be available to share. with
Okay,
us.
can we share those slides out with folks?
Oh, please do. Yes. And we put, I just want to say really quickly, particularly think about access. I think that we attach one of our flyers in English, but we have our flyers on our website in I think 14 different languages. And I don't know if we mentioned this, but several of our colleagues speak different languages themselves. So we're trying to meet people where they are live and in person, but we know that we are not going to be able to speak every language. We do use language access services, but you're welcome to share the slides and the flyers, and you're welcome to go online and grab them. You can download them and share them in any language with our
Hey, would you
thanks.
mind putting a link to your website in the chat just so folks have an easy access if they're in this room? And Brooke did mention some of the languages that your team
Oh,
speaks
good.
at the
Okay.
beginning of her presentation.
Thank you.
And then I also want to mention to you all, we will be having some new folks join us in the next few months. We are bringing in we're doing a training for our members with lived experience to help them sort of be ready for what does a committee mean and how do you participate? And they are building that right now. So we're hoping that our family advocates and our youth advocates will be stepping in July and August. Obviously, we have Leah here, but we could have more family voice in the space. And so we are working on crafting the supports that they need to be able to sort of participate meaningfully and confidently in this space. Leah is an excellent advocate and has a lot of experience, but not all family members have that opportunity. So more family voice, more youth voice coming soon. Please complete the survey if you have the time, and we will see you on June 24th at 3 p.m. Thank you all. Appreciate you.
Thank you.
Bye.